Thank you so much, Amir, for being here. And yeah, we can start. Thank you.
Okay. So let me go ahead and share my screen, and then we can kind of um, jump into sort of the introduction. So I'm so happy to be back from last year to present for you guys. This time around, we're presenting on speech intelligibility issues. And I want to preface before I even start anything in here and clear up what that word intelligibility means. So, a lot of times we see this word and we think it relates to intelligence or something like that, but that's actually not the case. Intelligibility just simply means how well we understand the spoken language. So I just wanted to clarify that word before we kind of jump into talking about more about the speech sound issues and things that we see in our population with Down syndrome. So as Sandra mentioned, just some disclosures about me. I've been a school-based speech language pathologist for 11 years. I've also been an adjunct professor at CSUN for 5 years, and I've provided a lot of clinical supervision to graduate students who are on their way to becoming professionals in the field. So that's sort of my background, and when you hear me give the rest of the presentation, that's sort of the lens that I'm coming from when I am speaking. I do want to apologize. I am suffering from the allergies as well. It was so windy these last couple of days, so my voice is a little off. So please bear with me a little bit here. So I'm just going to jump into like the hot button question that I get a lot, and I think that Miss Sandra was talking about that she gets a lot from you guys, which is what is the apraxia of speech? And this is a really this is like a buzzword. I would say that a lot of people throw around a lot, and we hear it a lot, but what really is apraxia of speech, and how do you know if your child has it, and how do you know if the information that you're getting is something that is really what's going on, and the root of the issue that you're seeing with your child. So um, I will kind of try to briefly go into this. So basically, apraxia of speech is a neurological condition. So it happens in the brain, and it affects motor planning and programming of speech sounds. So kind of in layman terms, what that means is, you might know what you want to say. Everything works pretty well, like your tongue, your teeth, your jaw, everything's working, all good, but somehow there's a misconnection that's going on between what you want to say and how you kind of plan how you move everything to say it. So this is kind of a tricky thing to diagnose because we're talking about something that's going on in the brain. A lot of times what we'll see in children's speech, and this can also happen in adults as well, but we're primarily talking here about children with Down syndrome, or honestly, any child. What you'll see is there's difficulty sequencing those sounds. So kind of moving from one sound to the other is a little bit difficult to kind of coordinate that movement. You'll see a lot of trouble with multi-syllabic words specifically, because more to coordinate, right? The longer the word is, the more sounds you have to kind of go between. Oftentimes we'll see vowel distortion. So the vowels won't be the correct vowels, or they'll be a little off from the vowel that we were expecting in the word. This one's really key, that there's inconsistent errors on repeated trials. So for example, if the word is cat, We might see a kid produce it ca, we might see the kid produce it tat, we might see the kid produce it mat, we might see it come out like 3 or 4 different ways upon repeated attempts of that word. And that's one of the really key characteristics of apraxia, is that it's hard to find a pattern in the errors. And then a lot of times we have prosody errors. So what that means is sometimes we sound like a robot, right? Like the stress and the pausing between words is kind of off. And so you don't get that natural flow of speech that we would expect. And so there's a ton more characteristics of apraxia out there. In order to actually have apraxia, it's not enough to say like, oh, I just have vowel distortions, or I just have this difficulty with multisyllabic words. It's not like a one characteristic thing. There has to be multiple characteristics in order to kind of effectively diagnose this. So it's really important that, and I'll kind of, you'll see this is my sort of running theme today, is it's really important to seek a speech language pathologist who can do that kind of a diagnosis, because you know, we want to make sure that whatever we are finding the correct thing and we're treating it correctly. Can tell you what apraxia of speech is not as well. These are kind of some myths that are out there. It's not actually a very common disorder, honestly. The reason we bring it up today is it does have a higher prevalence. It does show up more in individuals with Down syndrome. But as a general rule, even within Down syndrome, it's not something that every kid with Down syndrome is going to have, or every kid is going to sort of manifest. And I think sometimes, like I said, this becomes a buzzword that we use, that like, oh, my kid has apraxia, my kid has apraxia. Well, I'm not sure if they really have apraxia, because there's some other things that could be going on that, you know, it might be a very difficult profile to assess. And we want to make sure that, again, we're really honing in on what is actually happening here. Not just saying, oh my gosh, I see all these errors and I don't know what to do with them, and so therefore it's apraxia, which can happen sometimes. So especially in the medical sort of model. So that's why I have my second point here, that apraxia of speech is not something a doctor can identify or prescribe treatment for. I can't tell you how many times I've gotten prescriptions that come to me from doctors saying, you know, oh, this kid has apraxia and they need, you know, therapy 5 days a week. And doctors, or your general pediatricians, your general practitioners, they don't really have that specific knowledge like a speech language pathologist does about speech and language disorders. And so I don't know how many doctors truly have the training required to appropriately and accurately kind of diagnose something like this. And the third really big thing that I've seen is that apraxia speech is not something that can be diagnosed if the child is nonverbal, meaning if they're not using words, they're not able to imitate words, we can't say that they have apraxia of speech, because like I mentioned before, some of the characteristics of apraxia of speech is that they have to be able to produce those multiple trials so that we can see what those errors look like. And if they're not doing that, then how do we know that they have this going on? So I've seen a lot of this also come to me, where a child might not be speaking yet, and a parent comes to me and says, I know my kid has apraxia of speech because, they're not. And it's like, I'm like, I don't know how we could. I mean, it's very possible. It's very possible your child could have apraxia of speech, but there's no way of knowing that if they're not able to repeat words and go through that kind of an assessment for us to sort of determine um, that it really truly is apraxia of speech. So that's something I just want to caution parents about. It's there's so many myths out there, and again, I would really encourage you to seek a speech language pathologist who can really make that call um, in order to really be sure that that's what really is going on with your child. The other thing I'll just kind of give a little caveat about private practice and sort of medical based models. A lot of times children have general speech language disorders, which I'm going to go over some of those other ones. They may have some of those other speech language disorders, but apraxia of speech is something that is billable by insurance and things like that. So sometimes they mark apraxia of speech, and that's what they're billing, and how they're getting reimbursed for their services. But again, your child may not really have apraxia of speech. They're just marking that because that's how they can bill for it. So again, I just want to caution you because I've just seen so many families get this apraxia of speech stuck in their head of like, my kid has this, my kid has this. And it's been so hard to kind of tell families like, actually, I think it's this or it's that, it's something else. And it's hard once you've kind of latched onto that. So I'm going to go over some of these other speech sound disorders that we also see in children with Down syndrome, so that you can kind of get an idea of what I'm talking about with some of this. And again, I just want to reiterate, a child with Down syndrome can totally have apraxia of speech, 100% can totally have it. But there are other speech sound disorders out there that I think are not, like I said, like a buzzword like this. So we may not always hear about them as much, and therefore we may not be as aware that they exist. So one of these speech sound disorders is known as an articulation disorder. And you may have heard this, may not. But basically what this means is that you have difficulty moving your articulators. So difficulty moving the tongue, the jaw, the lips to make this sound. So it's a very motor, physical thing. I always have my grad students go, put your hand right here. This is what it is. It's this part that's having the difficulty. And so what that might look like is, if, for example, if we wanted a kid to produce the k sound, that K sound, they might have difficulty moving their tongue back for it, which is where we produce that k sound. And so they may produce what we call a distortion. So they may do something like a or whatever, like something close, but not quite. Or they might substitute that sound for something that's motorically easier, right? So a lot of times in children with Down syndrome, it's much easier to produce those T's and D's. So instead of your K, you might produce a T sound instead. So you might say tootsie, right, instead of cookie, or something like that. Another another speech sound disorder that we might run into are phonological or phonology-based speech sound disorders. So what that means is that the child is having some difficulty understanding the rules of the sound system. They can physically move everything, but there's a rule up here in the brain that's saying, oh, every time I see a sound or I hear a sound at the end of the word, I'm just going to drop that. We call that final consonant deletion. Or the example I give here on the slide is they're substituting T for K consistently because that's the pattern that they've registered in their brain. And that is a pattern known as fronting. So again, this is where it gets complicated, right? Because I just gave you an example with articulation where a child might say tutti for cookie, right? And it could be because they have difficulty getting their tongue back. But a child could also say tutti for cookie if they have a phonology-based disorder because they have a rule that every k sound is going to become a T. So how do you know? Is it articulation based? Is it phonology based? Right? Again, a speech language pathologist is going to be doing a comprehensive evaluation of your sound system. Hopefully, they're going to be doing an oral mechanism exam. So they're going to be looking in the child's mouth, asking them to do some things that will kind of help them make that distinction between these two disorders. And then, if this wasn't complicated enough, we're adding a third thing in here, which is dysarthria. And dysarthria is really the difficulty producing the sounds due to a weakness. And this is actually something we see very, very, very commonly with individuals with Down syndrome. And this is why it's so important, again, to have that differential diagnosis, because with dysarthria, again, you're going to see, I'm taking that same example of making that k sound, but this time it may be, maybe you're getting sort of an approximation to it, but it's not very crisp, right? The sounds aren't very crisply produced. They may sound a little slushy, it may sound a little slurry, because the muscle is a little weak and you're not able to get that kind of crisp contact that you need to make that sound. Dysarthria and apraxia of speech have a lot of similar characteristics. They have vowel distortions. They have difficulty producing multisyllabic words, right? So there's a lot of, they have prosody errors like we talked about with apraxia of speech. So it is really, really difficult to, again, make that diagnosis of what's going on, because we really have to rule out certain things. We really have to do a thorough evaluation to determine what's going on. And the other sort of thing that we can add to this to complicate even further is that you could have a mixed speech sound disorder. So you could have a couple of these things going on at the same time. You may not have exclusively one or the other. So we have 4 sort of different things that we're looking for when we're checking for speech sound disorders. And especially when we're looking at kids who have Down syndrome, what they have found is that the research shows that usually, and again, not for every single kid, but usually they will find articulation and phonology disorders are the most prevalent in childhood. I do want to also, sorry, I didn't say this when I talked about phonology, but I do want to make a comment that a lot of phonological errors are also, and articulation errors are also developmentally typical sometimes too. So a lot of kids at like 2, 3, 4 years old, sometimes they're making these errors, but we actually expect them to make those errors. It's very typical as part of typical development. What we see in individuals with Down syndrome is that there is a delay, even in that typical progression of articulation and phonology disorders. So we're really looking out for those two. And then, like I said, a lot of times we get kids who with Down syndrome who present with dysarthria. So over here, one of the articles that I was reading was saying that it's almost a 40% prevalence of dysarthria versus an 11% prevalence with apraxia of speech. So you can see again, right, that there are kids with apraxia of speech and Down syndrome, but that prevalence is less than we think, right? It's not as overarching as part of this particular population. Okay. There are also some other factors that impact intelligibility. So these are some of the things that we kind of consider as we're doing this assessment. You know, we're trying to rule in what is going on, which one of these is really going on. Is it a mixed thing? But we also have to kind of take into account that, especially with Down syndrome, because it's a syndrome, right? We have certain common facial features and facial structures that we're working with. So the oral motor piece is a really big piece with individuals with Down syndrome. So a lot of times anatomically, what we see is children with Down syndrome or individuals with Down syndrome have a smaller oral cavity, so smaller space sort of to work with, right? And they have usually a narrow, high arched palate. And the palate's like the roof of your mouth right here. So their palates tend to be like this, which kind of limits the amount of space that you've got to kind of work with inside the mouth. And that high arched palate is typically because they have larger tongues. So larger tongues, lower resting tongues, right? Because there's usually low tone. So the tongue is often sitting at the bottom of the mouth, right? And it's sort of heavier. What we see in other populations is that typically we're not seeing that sort of high arched roof of the mouth, because if you're just sitting at rest, and you guys can do this at home as well, if you're just sitting and you're not talking, where is your tongue resting? And for most of us, our tongue is resting up at the top of our mouth when we're not doing anything, right? And so that tongue is acting as a natural palate expander. It's not allowing that development of that high arch. It's flattening it out, right? And it's creating more space in our oral cavity, in our mouth. So that is why with children with Down syndrome, we see that difficulty, because you have a smaller cavity to work with, you have a bigger tongue to work with, and so it's going to be really hard to move it in there and get really precise sort of movements and precise kind of contacts with those to get those clear speech sounds. So that's something that we want to keep in mind when we're looking at kids with Down syndrome. I do want to say, sorry, before I kind of move, because I know I'm kind of going at a little bit of a speed here. If anybody has any questions, please put them in the chat as you think of them. I will leave time at the end, like Miss Sandra said, for questions, but I know sometimes as I'm talking, you get questions, so you can just put those in the chat, and that way we won't forget them as we go along. The other factor here that we want to take into account is hearing. And this can be big for individuals with Down syndrome. Approximately 2/3 experience some level of hearing loss. I've had a lot of kids with hearing loss who've had hearing aids, things like that. So just something that you want to keep monitoring. Children with Down syndrome are particularly susceptible to ear infections because of the narrow ear canals. And obviously, when we're trying to learn speech sounds, what we hear is going to be super important, right? Because if we're not hearing the sound correctly, if we're not hearing the word correctly, then it's going to be really hard for us to produce the word correctly. And so that's something that you definitely want to monitor as a child ages. The third factor that we have to take into account is cognition. So 80%, that should say percent, yeah, percent, present with a moderate intellectual disability. So sometimes during therapy, what can be a challenge is we may have a child who's verbal and has some good verbal speech, but it can be really hard in therapy to work on some of that because the child may have difficulty understanding the cues of where to put their tongue and how to move, their lips or how to move their jaw to produce that sound correctly. And I've actually encountered this a few times where I've had some students who were great. They could have conversations, they were answering questions, they were social, they were doing all these great things, but it was so hard to understand them. And when I tried to do therapy to really target those speech sounds, it was really difficult because I would say, put your tongue here, and they wouldn't be able to do it. Like they wouldn't be able to follow that direction, or they wouldn't, or they had difficulty. So obviously, we don't just give up if a kid has difficulty. We really try. We try a bunch of different cues. We try, you know, we try everything we have in our toolbox to try to elicit that sound or work on that. But I have kind of seen that can be an issue that crops up in therapy. I also want to say that for therapy for apraxia of speech specifically, it can be really difficult because apraxia of speech, a lot of the therapy techniques that we use involve touching the face. And if your child is averse to being touched or they don't like that, a lot of children with Down syndrome are very like, they have this spunky spirit and they want to do things on their own and they don't want you to do it for them. So there can be some resistance to that, and that, and really knowing if that therapy method is going to be a good fit for your child or not is important because again, not that we don't try and we don't, try different sort of things, but some of these speech sound disorders sort of lend themselves better to certain therapy techniques. So we want to just kind of keep that in mind. Every speech language pathologist has training in all of these speech sound disorders. I would say that every speech language pathologist should be able to treat all of these speech language disorders, but some of them may not feel confident in sort of diagnosing apraxia of speech per se. I think in the grad school curriculum, we really talk and we really focus more on the articulation and the phonological disorders. We do cover dysarthria and apraxia of speech, but I think it's something that diagnosing wise, some clinicians are not as comfortable as others. But in terms of treatment, any speech language pathologist is very, very capable of treating these disorders. So just to put that out there as well. So that sort of segues into some school-based treatment options. Therapy can be provided in a lot of different formats. In the schools, we tend to do, depending on where your child is, if they're in a special day class, if they're in general education, we may go into the classroom, we may pull kids out of the classroom. We do a lot of small groups, which actually I have found to be very beneficial for children with Down syndrome. I've noticed that, some of my more shy kids with Down syndrome, if they're like more reticent to kind of work on things. If they may shut down in an individual one-on-one type of setting, but once I get another kid in there who's also working on some stuff, they're a little more ready to participate because there's that sort of positive peer pressure going on. So that's something that I've seen that has worked nicely. Home practice can be something that you want to ask your speech therapist about if there's something that they'd like for you to work on in terms of certain sounds, or with apraxia of speech specifically, sometimes we want to target what are called core words, or sort of the words that the child is really invested in or really going to be using primarily to carry a lot of communicative intent. So for example, words like go and play carry a lot more meaning to them than, let's say, like elephant, or another word that maybe is not as frequently used, right? When we're trying to think about communication as a whole. I've had parents give me the names of siblings, of pets, things that the child really loves and wants to be able to say. And we've kind of made that sort of a primary focus. Like, okay, if your kid is really having trouble pronouncing sibling's name or pet's name, and they really, really love that, and you want them to be able to talk about that, we can focus on that word. That's an important word for your child, right? It has meaning for them in their daily life. So we really rely on parents for that kind of information of what are the words and the things that are important to your life, and that we can incorporate in our therapy. And then we want to keep in mind that overall communication is the priority. So again, that's why we kind of focus on some of these core words before we kind of get into sort of other, what we call fringe vocabulary, because we really want to give the child words that are going to be able to provide the most bang for your buck, right? Like, we want to give them words that really hold a lot of meaning and can be used in a variety of ways, so that communication expands. I will say a word about progress, in regardless of whether we're working on speech or expanding language with a child, even across disciplines, whether it's PT, OT, anything, in especially in children with Down syndrome, we sort of expect, I think, progress to go like that first line, right? Like, we're just keep moving up, right? Or sometimes we're like, okay, we know it might be a little slower, right? So maybe it'll look like that second line. But it's still moving up. Many times we see the third profile. And what that means is, I've seen this so much over my career where, a kid will suddenly have great growth in, their PT, their physical therapy, but then the speech will kind of like, won't be doing so well. Then suddenly they'll gain some words, or they'll gain some communication, and then another area might drop, or so we kind of see these up and down fluctuations, and it depends, right? Because with any child, there's a certain amount of cognitive resources, a certain amount of brain power. And to learn something, it takes a lot of brain power. So if we're learning one thing, sometimes we don't have that brain power to give to the other area. And so, like I said, you might see this sort of roller coastery kind of a profile. And I know parents tend to panic because they're like, oh my God, they had this and they've regressed, or they're not making progress. And I always tell parents, I'm like, you know what? This is so common. This is just so common. Please be patient. You know, we're going to keep working on all of this, and just, you know that it's going to look like this kind of roller coastery profile. And that doesn't mean that necessarily that the child isn't making progress. So I think that's a really, really important thing to kind of go into therapies knowing, because like I said, I think it can be frustrating when you kind of see this sort of dip in performance. You know, I think that can be frustrating for families. So just so you know that that's something that we kind of expect in we're doing all these therapies. And then just to kind of reiterate that, you know, I know we, as a society, we kind of prioritize verbal language, right? We want our kids talking, but these are other alternatives that are just as valid, right? So using signs or American Sign Language is a valid way of communicating. Gestures, pointing, reaching for things, using what we call AAC, or alternative and augmentative communication. That could be in the form of a device that has, you know, an app or a program on it where, you know, a child can access that to communicate. It can also be as simple as just a picture board, and the child is pointing to what they want, or things like that. So all of these are valid forms of communication. And I really want to make that point strongly because, like I said, I think you know, we all want verbal speech. That's a totally realistic thing, that, you know, expectation that, you know, I want my child to be talking, but sometimes, you know, we have to take other steps to kind of get there. And then there is the reality that some kids will have to rely on some of these other ways of communicating as well. So that's just something that we don't know. We don't have a crystal ball. Every child is so different in what they're able to kind of come with. But as speech language pathologists, we are going to try everything. We're going to, you know, do everything we can to make sure your child is communicating in a meaningful, functional way. So whether it's signs, whether it's gestures, whether it's AAC, whether it's verbal language, we are going to do our very best to support the child. So some final kind of things that I want to emphasize before I open it up for questions is, again, not every individual with Down syndrome will present with apraxia of speech. Like we said before, that there is that 11%, right? So it is there. But just so you guys have that idea that, okay, there are other speech sound disorders out there. If my child has a speech sound disorder, it's really, really important that we have that differential diagnosis, so that we have a speech language pathologist who's really looking, like I said, doing a really comprehensive job with evaluating the child, so that they can rule in or rule out some of those disorders, so that we can, because, you know, knowing which thing is going on, which, you know, whether it's apraxia of speech, whether it's articulation, whether it's phonology, whether it's dysarthria, when we know which one we're dealing with, then we can select the appropriate treatment technique, right? So if we are kind of not doing that differential diagnosis correctly, then we may be using a treatment technique that doesn't match, you know, the actual disorder. So if, you know, we're thinking, oh my gosh, this is apraxia of speech, and it's really not apraxia of speech, and we're doing, you know, prompt or some of these other techniques that we use for apraxia of speech, it's not going to be as effective as, let's say, using whatever other approach, because it's a different disorder. So I hope that kind of makes it clear about why that's so important, that we don't just sort of take one thing and run with it. We really need to kind of be consistently, because things also change over time, right? you know, your child's profile will change over time, and making sure that that's monitored throughout is really important. The other factors, like I said, that we really want to keep those in mind, like the hearing, the oral motor aspect, the cognition aspect. Like I said, not every kid is going to be a great candidate for certain kinds of therapy, and it really comes to knowing your child and knowing what they can tolerate. And you know, when I've had really honest and open discussions with families about, like, you know what, I know you really want to work on this, and you know, you want this for this to happen, but I think your child is just like, they're getting really frustrated. They're like, you know, and I don't want speech to be something that they hate coming to. I want speech to be something that they find meaning from, and that they you know, of course, not every session is going to be, yay, it's a party, like we're doing some hard work here, but I want them to find something meaningful out of this. I don't want them to dread coming or fight coming because we're doing something that's just making them shut down. And so if that's the case, then we kind of, I think, have to have a discussion about what is a better way to approach this, or how can we change the therapy, or how can we you know, work with where the child is at to make this meaningful for them and for the family. You know, that's really important. The other thing, again, progress can be very individual. It's really hard to compare kids, you know, and I know with social media, we sort of fall into that comparison trap, but just knowing that as you go into therapy, you know, the progress can be vary, and you might see that up and down profile. And then the last kind of point that I have here is that just all communication is valid. The reality is not every individual with Down syndrome will require speech therapy for specifically to target intelligibility. Like I said, they may not be a good candidate, but then there are some that are great candidates and are totally going to take off with this. You know, for some kids that are not good candidates, we may prioritize really getting in that functional communication and making sure that they're communicating you know, in a way that is understandable to you as the parent, and also for them to be able to kind of access their community, access their classroom and their friends, and all of that. So we may sort of shift gears in what we target based on what the child kind of comes in with, and how they react. So it's a very fluid process is what I want to kind of tell parents. It's a very fluid process, and you are a very important part of that process. Your input is a very important part of that process. And so, you know, that's how we can kind of maximize the benefit for our children, is by kind of working with families and finding what is working, what is not working, just keeping that open communication, you know, and doing what is best for the child, which is what we all want. These are some sources, just some articles, but I will take some questions, and I will say thank you for letting me sort of blabber all this time. And now I'll
Thank you
if there's
so
any
much.
questions that you
We have
guys
some
have.
questions in the chat right now.
Okay, let me stop this so I can take a look at them. Where is my chat? They've added so many things here. Here we go. Okay, let's see. Speech therapist and pathologist, is it the same? Can a speech therapist diagnose? Yes, a speech therapist and a speech language pathologist are the same thing. I think speech therapist is sort of the common layman's term that we use, but our correct title is speech language pathologist. So you might hear both used interchangeably. Um, can they diagnose? Yeah, we can diagnose speech sound disorders. Like I said, you may find that, and then I think that's the second question here. Can they diagnose apraxia of speech? Yeah, they can. There are some therapists that have had more training specifically with apraxia of speech. All of us, all speech language pathologists, we have to participate in continuing education. So we're always taking conferences and things to help us keep updated with the latest research and things like that. So yeah, we can diagnose that, but I would say that some therapists are a little more comfortable doing that versus others. I think the important part is not as much diagnosing it per se, but really identifying the sound errors and what is actually going on. So, like I mentioned before, with certain speech sound disorders, we see substitutions of sounds. Some of them we see where they're dropping sounds, they're omitting sounds. Some of them we see that they're distorting the sound. So they're getting close, but they're not quite making that crisp contact. So really looking at the nature of the errors tells you much, much more about how to treat it versus putting like a hard and fast label on it per se. But if you do see, sometimes therapists will write, possible difficulties with motor planning or motor programming, that usually is a hint that they're thinking that it's probably apraxia, and that's why they're writing it that way. They don't want to maybe call it out, but that's what they're suspecting. And sometimes it's really hard to diagnose, like officially diagnose apraxia before the age of 4. So sometimes that's what therapists will write in there when they are not sure, but they kind of want another therapist to know that that's what they're suspecting, and that's how they should kind of be treating the child. So it's kind of like a code, a code that we use. Nonverbal or kids who
I
can.
have a question.
Oh yeah, go ahead. Go ahead.
Oh, sorry. I wanted to know, are there going to be any like conventions or something like for a parent to go attend? Because it's been really hard for me to get speech services throughout my child's life. He's actually going to be 17 in a few months. And I wanted to know if there's a way, like, what is the best way I can learn these therapies for my son, so that, because I teach him at home. And, so is there a convention that I can attend to learn more from speech pathologists?
I mean, we have a lot of conventions. We have one right now. Kasha is going on. It's for professionals, but Kasha is CSHA. It's going on right now, actually, this weekend. And it's in San Francisco this year. But it's an annual conference. We have it. It's mostly for professionals. But what I would suggest is we also, there's some great websites out there for apraxia of speech specifically, or if you're not sure and you want to consult with a speech therapist. Apraxia Kids is a great website. I believe it's apraxiakids.org. That's a great website that you can go to. I'm not sure. The last time I saw, I think you could do like a consultation, which is probably what you're looking for. I think I would look out for consultations because there's a lot of speech language pathologists that do consultations, and that might be probably helpful to you in terms of getting what you need.
Okay, thank you.
Yeah.
I wanted to add that CSUN has also a speech and language program.
Yes.
And so they offer therapy there, assessments and therapy. And
they offer therapies for my teenager?
They all,
yes.
And it's a lower cost than if you went to another place. I just want to mention.
Oh, thank you so much. That's so good to know. Okay.
Yeah. So what the clinic does on campus is, you know, the student clinicians would be evaluating, and then they kind of, like Miss Sandra said, it's I think a sliding scale how they do the payment options. So, yeah, it tends to be
And
more affordable
is
than
it available? Is it available year round? Like, can I just go in there and
yeah,
sign them up? Oh,
yeah, yeah.
okay.
You can call that office. I can find the number for you, but it's a speech language and hearing clinic at CSUN. And
Okay.
yeah, they can take your intake, they can evaluate him, they can you know, work with you.
Oh, that would be amazing.
Yeah.
Okay, thank you.
Yeah. Okay, I have a question here. Nonverbal or kids who can say only the sound of the first two letters or the last two letters. Can they receive therapy, apraxia, or the other? You mentioned I have a 5-year-old boy, nonverbal only sounds of the now last two letters, most common we use. Yeah, yeah, they can definitely get therapy, that's for sure. Again, you know, it would be good to kind of have a good assessment, a comprehensive assessment done, so that we can see what, if there's a consistent pattern, then you know we can know how to target that versus it sounds like there is a consistent pattern because you're saying most of the time he's saying the last two letters and not the first. But yeah, definitely something that can be done. The other thing I didn't say is, you know, sometimes there may be a speech sound disorder, but the child isn't producing enough language yet. So sometimes we like to target that first so that we can get more content, and then we can kind of go in and clean it up with the speech sounds. So that's a technique that a lot of speech therapists use. So just something to keep in mind. But yeah, definitely they can do therapy for kids who are producing some of those sounds already. At least language therapy, if not speech sound therapy. My son has been diagnosed with dysarthria and apraxia by 2 different non-school-based SLPs. What interventions, approaches, techniques, tools should the school SLP do or offer? Our lifelong battle has been schools saying they do school-based model, not medical model, or CAS approaches are not evidence-based. Okay, I would argue that I don't know why they would say they're not evidence-based. What can an SLP, a school SLP, do? They can do speech sound therapy. I don't see why they would say that. I don't know which approaches you're talking about, but there are a lot of evidence-based approaches for apraxia of speech. REST is one of them. DTTC, which is dynamic, tactile, and temporal cueing, is very effective, and that's very evidence-based. I don't
the first one. You said
REST. So actually, let me put them in the chat because I think that would be probably easier. So REST,
REST,
REST, and DTTC, which is dynamic, temporal, and tactile, and dynamic, tactile, and temporal cueing. Those are evidence-based practices. The only one I can think of that they would be saying that for is prompt. Prompt is technically not as evidence-based, I guess you could say, but that's the one that does involve a little more touching of the face.
it's always been the one that they kind of say no to.
Okay.
But I
Yeah,
haven't heard of REST and I hadn't heard of DTTC yet.
Yeah, and I would say that, prop's not the end all be all of apraxia therapy. Like
Right.
there are like the other ones are just as effective. I think the key is that we're not like when you do apraxia therapy, you're not picking like, oh, I'm going to work on the T sound. Oh, I'm going to work on the B sound. The really, really important thing about apraxia therapy is you're focusing on the movement between the sounds. So, it should be in words or syllable shapes or things like that. It shouldn't be targeting just like one sound in isolation or one sound, where it's really focusing on movement. So a lot of times the goals that we write for apraxia should be like working on VC, vowel consonant shapes like up and things like that, or CV, consonant vowel like go, by, the shapes is really what's important. And these like REST and DTTC, they're just techniques. So it doesn't mean, like I said, you don't have to have a prompt trained therapist. You don't have to have anything like that. But they should be able, like any speech language pathologist should be able to work with a child with apraxia. And if it's a matter of they need more training, that's maybe something that the district or somebody should be providing. But yeah,
and the speech sound therapy can be delivered both virtually and in person, probably then.
Yeah, I would say virtual can be, it depends. I've had some good success virtually, and then I've had some kids really struggle because they needed that touch. They needed the tactile cues. So some of that obviously you can't give over a screen, unless maybe an adult is sitting with them or something like that. So that
I'm usually there with him. Is the REST and the DTTC, are those physical also touch based or
no, I'm not as familiar with REST. Honestly, I mostly use DTTC, but that one is not as touchy. Yeah.
Okay. So as long as they know about speech sound therapy, they should be able to address, and with the emphasis on movement and shapes, the shapes of sounds, they should be able to address school-based. Yeah. It would be weird. It's weird to me to hear a school saying that, like, oh, your child has apraxia, we don't treat that. Like that's odd. That's an odd statement to me. Being in the schools myself. So yeah, but I could see, like, reading about the evidence-based practice type thing, I could see a school saying, we don't necessarily have to guarantee we're providing you with prompt. That might be something, but that doesn't mean that they can't give you therapy. And what does speech sound therapy look like? What should it look like?
So it depends, right? Like if we have a child who is presenting with the articulation, like we talked about, I would be focusing my treatment more on, okay, like this is where your tongue needs to go, right? It's focusing more on placement of where the tongue needs to go, where the jaw needs to go, all that stuff. If I'm looking at more phonological based disorders, I'm looking more at, I need the child to understand the sound contrast. So I need them, because it's a brain thing, right? So I need them to understand, like, an F and a P are two different sounds, right? So we might do what's called minimal Paris therapy. We might do other types of techniques that really brings to the forefront that, oh, these are two sounds, and it might involve, them hearing and pointing to the right one, or then saying this one, or so that will look different. Dysarthria is a little tougher because, again, it's hard to kind of build. It still will go back to motor learning. Even apraxia is more of a motor speech disorder, so you'd be looking at a lot of repetitive trials. A lot of, like I said, with apraxia, you're doing movement. So I might, I might be doing the same word like 20 times. I may not
Yes.
have like 100 targets that I'm working on in that session, but I might be doing like, 3 words. I might pick that whole session, and that's what we're doing the whole session,
Exactly.
like 100 times.
Right, exactly.
So yeah, it's going to look a little different based on, does that kind of answer the question?
Yeah, so it basically speech sound therapy is articulation, addressing the articulation disorder, the phonological disorder, the dysarthria, and the CAS.
Yeah, depending on what your child presents with.
Yeah, well, he's got everything.
Yeah. So hopefully they're spending some time doing a little bit of everything.
Okay. All right. Thank you so much, Samira. Are you available for consultation with our school therapists?
I don't know, because I work in a school myself, so I don't know about the hours and things like that, if I would be able to kind of make that work. But
They intended to come
know,
today. Both of ours intended to come today, but they, it's the weekend, so it's hard for them to be able to attend. But they were very open to attending.
Yeah, I was gonna say that there are definitely some people that I could probably refer you to that would be that are private practitioners that might be more able to kind of work in that capacity, like providing consultation and maybe attending with you and things like that.
Great, thank you.
Yeah. And then I think the last question here is, what resources can we provide our school-based SLPs to be able to address dysarthria and apraxia in school? I think the trainings are really important. A lot of us, in the schools, we have to attend in general trainings every year. So sometimes the district puts those on. Sometimes we have conventions like the CASHA convention where we go and we do these continuing education. So I think just, mentioning even to administrators or anybody like, hey, is it possible to get your staff trained? There's even some free trainings, honestly, online for professionals that they can do free of cost to get trained a little more in how to treat, especially apraxia. So there's a lot of training opportunities. I think that's the main thing, because once you get that training, then you're more able to kind of provide that help in the, to parents and to kids in the schools.
Thank you.
Yeah.
I feel like I'm like Margie. My son is 25 and he has just about everything that you explained to and more.
Yeah, totally relate.
So my son has a dual diagnosis of Down syndrome and autism, but one of his big problems is that he can't put sentences like, in a full sentence. He says store going, I don't know, something, like not in the, I want to go to the store, so it's really rough. And then additionally, being obsessed with certain things in his life that you can start talking about, oh, this is what we did today. He takes it back to his preferred topic, so, so everything's always quite a bit, but thank you so much. I'm gonna try to get that information from Season, so anybody's interested, because most of us are here local. I think maybe we can send the information and see how people can. Are you?
Yeah, and I can email. Oh, hi.
He's attended your presentation as well.
Oh, hi. I hope you liked it.
And we have, whoops.
Oh, great.
Oh, I see. You have, is it a Proliqua there, a touch chat?
Yeah. Everything and everything.
So you would be able to send us your presentation?
Yeah,
Okay.
I can send also the, like, I know I mentioned Apraxia Kids, and I mentioned some of these other conventions and things, but I can even find that training, the free training, and send that over as well. That might be something that, mom can forward to the district and say, hey, this is a free training. Maybe you want, you can have your therapist get trained for that.
Thank you so much. Appreciate it. And thank you so much, Samira, for spending your morning here with us. And also all the attendees, thank you for spending your side of the morning with us. But so I wish you guys to to enjoy the rest of the day, your weekend. Today we're having a dance at 3, celebrating World Down Syndrome Day. So today, this whole month we're celebrating, Samira. So just want you to know that.
I'm glad I got to be part of the celebration.
Thank you so much, and thank you everyone, and have a wonderful weekend. Thank you.
Thank you. Thank you for having me.